Good afternoon, sir.
Hey, good afternoon. When you were talking about a beautiful seaside city, I thought you were talking about Trivandrum, but we were not a French colony. Otherwise, we fit the bill.
So John has been to Trivandrum, but not to Pondicherry, so I have to describe Pondicherry to him.
John, hi.
Good morning. Good morning, Raj.
Hey. I know.
Yeah.
Thank you for that smile, I know. Dinesh, you should learn to smile like I know.
Yeah, guys.
I was smiling because I can see the training room, the teaching room at TIPS, where the course attendees are gathered, and I have good memories of that room. That's part of my smile.
You spent the best part of 3 months there in that room.
Yes. 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 They would only release me on weekends.
Oh, it's time. Hey, sorry, I didn't know. Mary, hi.
Hello, Dr. Rajagopal.
Hi. Vidya, how much time do I have for the presentation and how much for discussion? Sorry that I forgot.
This session, we have kept it open, sir, so you can take as long as you want.
In this particular session, I think most of the people sitting out there have seen this particular presentation. I have made this presentation to a lot of people. So what I suggest is, I shall go through the whole thing in about maybe 70 to 80 minutes is what it'll take. What do you want me to do, Vidya? Should I take discussion as we go through, or shall I just finish the presentation and take the discussion?
You can discuss as you go through as well, sir. That is also fine.
So, anybody who wants to interrupt me will raise their hands and get Vidya's permission or Sri Devi's permission and start. Thank you. Thank you.
Sir, raising hands may not be seen because of the shared screen. So better that they chat. They just say, you know.
Oh, I didn't see you, Nandini. Hello.
It's okay, sir. Hello.
Hi,
So please.
Hi, Ikbar. Okay, Sri. The first slide on. So, as I said, the majority of you have been in the classroom when I talked about this particular subject already. A few have not, but the majority that I see in front of me have. So, because there are a few who have not seen this, let me explain that what I mean by difficult pain in this context is pain that's not easy to control by a simple application of the World Health Organization analgesic ladder by the oral routes. And what you see on the screen are two oft-quoted studies which showed that in 71 to 76% of patients, there is, in one it said good pain relief, the other said satisfactory pain relief. And when we say satisfactory, it means satisfactory to the patient. Now, this is something that we are not very comfortable to accept, that 1/4 of the people would still be filtered out, would continue to have unsatisfactory pain relief on the WHO ladder. And both of these studies were in the cancer population. Now, if you include non-cancer pain, naturally, the percentage of failure will be much, much more for two reasons. One is that non-cancer pain is often more difficult to treat. And two, we would not be using opioids in the same fashion in non-cancer pain anymore. I am giving a 10-step protocol here. I apply for anticipatory bail. This is not an official letter, totally unofficial. It I am taking responsibility for this protocol. The first, this is mostly to remain myself, not to put the blame on the patient when pain is satisfactory. There may be an emotional element of the pain. There may be psychogenic pain, or at least a component, but still the pain is real. Even if it is hysterical, the patient is suffering. So we start by believing the patient. Second, again, because I am not an oncologist or an HIV physician or a pulmonologist, I remind myself that I will make foolish mistakes if I do not think of correcting the correctable cause. If in a person with cancer of the lung, complaining of back pain, or a funny feeling in the legs, I do not think about spinal cord compression and do not do the needful, if necessary, to get the patient irradiated immediately. The consequence would be paraplegia. 3. There is a huge, in this case, hand to stomach gap. The hand that writes the prescription and the stomach into which the medicine is supposed to reach. We write prescriptions. Even if the patient and family has understood it adequately, there may still be many reasons why they may not take it. Very often, our relationship is over 15 minutes. The neighbor and they have known each other all their lives. And if the neighbor says, "Oh, don't take this medicine, it plays hell with your tummy," the patient is unlikely to take it. And when we check adherence, it is not enough to ask, "Have you been taking all the medicines regularly?" It is necessary, especially when pain relief is inadequate, to sit down with the person, take one medicine after another, and say, "How many times are you taking this?" And a common experience is that when we say 4 hourly, the patient thinks 4 times a day. And in relation to adherence to treatment, a common problem is the cost. Now, we give free medicines to all poor patients within reasonable limits, but many institutions do not. And we prescribe medicines which are expensive. And I don't know if there's somebody from MNJ there in the group.
No, sir.
Okay, not today. Okay. There was a Dr. Evelyn, and she has written an essay on her experience of one person being prescribed fentanyl. The family spending all their money to pay for it for a week, and then that is 2 batches, and then deciding that they will allow him to be in pain rather than take up this expense. The difference in cost of available opioids is so striking. There has been a lot of discussion recently after an article appeared in the National Geographic. After a television program appeared, a video appeared in the National Geographic channel. Very damaging video where the journalist is practically accusing all of us. Jim Cleary happened to be there, but the accusation is, we are not preventing this calamity. We are allowing the industry to bring in expensive medicines. And I was very unhappy when in the list of ENDs, we, the palliative care fraternity, brought in oxycodone into it, despite all the things that have been happening in the West. Something to be cautious about for the future. So, first was believing the patient about the pain. The second was looking for correctable factors. The third was checking out for adherence to treatment. And the fourth, I have put in as checking for emotional factors. No, I don't have to say this. All of you would have had the experience. I have had this time and again. And especially I remember a young woman with CA colon who for almost a month could not have pain relief, satisfactory pain relief. Eventually, once she decided, yes, I am going to die, it cannot be cured. Okay, let me plan this and this and that. That acceptance and then pain relief became easier. So that's also a very real exploration that's necessary. At this point, at least I would spend time reviewing the regime in the ladder. After all, the ladder has only 3 kinds of medicine, none of you. There is very little that for us to play around with that. A lot of to play around with adjuvants, and third of course opioids. So particularly adjuvants, I would spend some time reviewing. I'll review the nature of pain. Am I missing something? Maybe a colicky pain, or maybe the chat is blocking my screen. Is there something you can do easily about? Okay, that's much better. Okay, maybe you can come over. I'm feeling very lonely. I will review the nature of the pain and reconsider adjuvants. When we talk about adjuvants, we will particularly remember that in neuropathic pain, the costliest is not necessarily the best. Remembering the relevance of adherence to treatment, the cost on adherence to treatment, I'll call upon everyone here is not to be superstitious. I try not to be superstitious about tricyclics. I willing to look at the evidence, but I look at the evidence also taking into consideration who funded the study. And in a previous session, I think it was in the session that Vijay did, Nandini pointed out one very important point that the international guideline is being presented. Something with a better energy is classed in the bottom. That is tricyclic. Something with a worse energy, pregabalin, comes on top of the list. So we are all programmed into believing that pregabalin and gabapentin are the best. Maybe we need to think again. Well, if you want evidence, you can find a lot of evidence in various places. But this is from a synthesis of recommendations of several meta-analyses, where in neuropathic pain, generally, and of course it's a generalization and it is not specific for cancer, that is taken for granted. The largest number was in post-herpetic neuralgia and in diabetic neuropathy. Diabetic neuropathy I'll talk in a minute. But generally, this synthesis of recommendations recommended tricyclics as first line, and the others only in the second line. Sorry. And here is one more algorithm based on meta-analysis. This is from Ireland, and they specifically in diabetic neuropathy have put in duloxetine as the first line. Personally, especially after seeing this, I started doing the same thing. I would start with duloxetine. But in most other neuropathic pains, I would start with a tricyclic rather than inhalants. And amitriptyline and pregabalin would be the second choice. And among adjuvants, I would also mention something that we do not always think. But particularly the anesthetist will feel more confident in this. Let me put in a word of caution. Lignocaine is a medicine that is a narrow margin of safety. It is not always effective, but I have seen remarkable benefit with some other. And if there is a remarkable benefit, then maybe we are able to follow up with an oral antiarrhythmic agent as the drug of choice. So one problem is there's a narrow margin of safety, and the second factor is that doctors and nurses are not good mathematicians. We make mistakes in calculation. In a medicine like this, a mistake in calculating in terms of milligrams converted to ml can be catastrophic. I am still at that fifth step where we were reconsidering the regime, particularly seeing which adjuvants can be changed, can be modified. And we mentioned drugs for neuropathic pain. We mentioned looking at the nature of the pain, particularly looking for things like colicky pain. But also we talked about the choice of the adjuvant. One thing that I forgot to mention, I have no study to prove what I say, but I think it makes natural sense. If we are starting with one medicine, build it up to an optimal dose before bringing in another, unless you are starting two at the same time. Say, for example, whether we are using, what I see very often is a patient receiving 10 or 25 milligrams of amitriptyline and 90 and maybe 75 milligrams of pregabalin twice a day. Both are usually inadequate doses for many neuropathic pains. So if left to me, I would build up the dose of one rather than start two concurrently and then keep fiddling with both. Both are then, I fear, will turn out to be inadequate doses. So, reviewing nature of pain and regime was my fifth step. Only now we are, so far we have been reviewing the situation. Now in the last 5 steps, we are proceeding to do something. Again, can we do any intervention? I would say, like including the anesthetists who are coming to palliative care, we sometimes do not think early enough about interventions that can be done. I'm not saying that it's something to come only in step 6. Maybe even when the patient comes, say there are patients in whom I will do an intervention straight away. I will also say that I do any intervention like that only in about 5% of patients that I see. But when in doubt, go to Vidya, she'll give Vijayanand Sapri. And it is not, some people call it step 4. That is, after steps 1, 2, 3 are finished, then you consider intervention. I don't think that is in any way rational or scientific. If it is of any use, maybe depending on how invasive it is and how affordable, we should consider it at the best time. And of course, we always underestimate non-pharmacological measures. Would simple massage help in this patient who is always complaining of aching in the limbs? Transcutaneous electrical nerve stimulation, which is very inexpensive, but very effective in a few patients, not in the majority. So, I mean, that is another thing that I would consider. Now we come to opioid switch. I had put it down as less important earlier, but now that methadone has come into the market, maybe we will take it more seriously. We all know that there is a proportion of patients who do not tolerate morphine well. We will come to the physiological basis later. No, sorry, pharmacokinetic basis later. In most countries, you can switch from one to other. Those who do not tolerate morphine well, maybe you are increasing dose from 10 to 15 milligram orally, and the patient is already getting delirious or myoclonus or unpleasant dreams. Now, maybe it is possible to switch them over to another opioid. Fentanyl being so expensive and methadone being so inexpensive, tomorrow we may use it. But a word of caution, for the last week we have been doing these evening echo meetings, specifically on methadone. It is not something that we'll take lightly. We'll consider it a very precious, very important medicine that will relieve a lot of pain in this country. But we also fear that if it is used by people who do not study it deeply enough, it can cause calamities. So, step 1 of step 7 is to understand methadone. I've never used it, but I've been learning so much from the others in the last couple of days. In this group, I think MNJ is the only institution which has already procured it. But it's a question of time, we will all be able to procure it. So, I repeat, the kind of patient who does not, who goes into neurotoxicity, unpleasant dreams or myoclonus and delirium with a certain dose of morphine may do much better when switched to another opioid. Yet another one. Can some people respond better to parenteral morphine than to oral? My answer, yes, emphatic yes. Time and again, we have had patients where oral morphine is not tolerated. They get delirious. You switch over to a subcutaneous infusion and they do remarkably well. How do we explain this? There was some confusion regarding this in yesterday's echo. Granted that our understanding of the kinetics or the dynamics of morphine are poor. There is that question mark. We believe that morphine 6-glucuronide is an active metabolite which accounts for much of the clinical analgesic action that results when we give morphine. Possibly the analgesic action is more because of M60 than because of the morphine molecule per se. Whereas we believe that morphine 3-glucuronide is possibly responsible for the side effects. There's more or less circumstantial evidence, like many people who produce more M3G are seen to have side effects, though we have no proof of cause and effect. But genetically, a proportion of human beings during the process of metabolism create more of M3G. Glucuronidase mechanism is different, so that some people, I don't know the percentage, but at a wild guess, let us say maybe 10 to 20% of people may metabolize in this fashion with producing more of morphine-3 gluconide, and they could be the ones who get easily neurotoxicity. So imagine, between oral administration and a parenteral administration, could there be a difference in the quantity of metabolites that arise? When we take the medicine orally, it's getting absorbed from the intestine, passing through the liver for fast metabolism. Understandably, because the liver is bypassed, if it is a parenteral administration, production of these metabolites would be less. More of the action is then due to the parent morphine molecule. So because the liver is bypassed, it appears that less of morphine-3 glucuronide is produced when morphine is administered parenterally. Therefore, if the patient does not seem to be tolerating morphine, we cannot afford fentanyl. We do not have methadone yet, or we are not confident of using it safely. There is a case for putting the patient on an infusion of morphine. Or suppose you do not have the device, a syringe driver, or you cannot afford to send a syringe driver with the patient to the home, and the patient needs to be at home. Maybe 4-hourly injections are still given. What we have done time and again is to send the patient home with a subcutaneous butterfly needle and give a syringe loaded with maybe a 20 ml syringe, where 1 ml after dilution is on dose. We calculate in such a way that if the family member pushes in 1 ml, the patient will get on dose. So we can, one syringe will last for 2 or 3 days, and then the patient's family brings back the syringe and takes back another loaded syringe. We do not send ampules back. Is it legal to give for the family member to administer morphine? Okay. Is it legal for the family member to administer insulin at home? Is the danger any less? If people can administer themselves insulin, they can do this also, but because of fear of diversion, we do not permit ampules to be sent away. Instead, that's the compromise that we do. We give loaded syringes. And there's a position paper by the Indian Association of Palliative Care, thanks to the initiative of Dr. Stanley McAdam at Bengaluru. There is a position paper which says that patients' families, that it is advisable when necessary for patients' families to administer injections at home. There is no law covering this. That position paper is what will justify us. But understandably, we have to train the family adequately and monitor as at least over the phone as frequently as possible. And understandably, once a week it will be good to change the site of the subcutaneous needle. So this is feasible only if the patient can be brought once a week, or a home visit can be made once a week. Well, if we are not doing the administration by the patient at home, even if it is in the hospital or your hospice, that recommendation is still the same. Either a subcutaneous infusion or 4-hourly subcutaneous injection. Understandably, this is feasible mostly for patients who are approaching death. We are getting closer to the end. This is step 9. Can I help to review the phenomenon of central sensitization, what's otherwise called a wind-up. The term wind-up arises from winding up a spring and making it tight. So here is the theory. On one end, you have the peripheral nerve ending. That's the nociceptor, which senses pain. Electrical impulses are generated, which travel through the peripheral nerve to the dorsal horn of the spinal cord, where I have marked it with red. Now, what seems to be happening is, as the impulses keep increasing with time, that's an unrelieved pain. What seems to happen is something like a traffic jam. So many impulses go that at the level of the dorsal horn, there is utter chaos. There is chaos in more ways than one. For one thing, the dorsal horn cell becomes more and more and more sensitive. That is, today, if one impulse from the nociceptor or peripheral nerve ending causes one impulse to go from the dorsal horn to the brain, day after tomorrow, for every impulse going from here, 10 impulses will be generated from the dorsal horn cell. That's what we mean by central sensitization. But coupled with this, there is also what's called a neuroanatomical reorganization of the spinal cord, or actually, I think the better term would be disorganization of the spinal cord. It loses its integrity functionally, and a lot of chaos results, so much so, it can account for allodynia. Ordinarily, touch should be perceived as touch, but because of the disorganization, touch is also perceived as pain. So, central sensitization causes worsening of the intensity of pain, but it also causes abnormal sensations and, of course, hyperalgesia also. Now, we know that this is a real phenomenon, not only in neuropathic pain. In a way, this is a way in which a nociceptive pain, when untreated, gradually acquires a neuropathic component. But because it is more difficult to treat and long-standing, very often neuropathic pains demonstrate central sensitization more often than nociceptive pain, but it can happen in both. So what do we do about it? The predominant neurotransmitter involved in the process of central sensitization appears to be N-methyl-D-aspartate. And so the anesthetist would immediately have the answer. The treatment would be to use ketamine. There would be other NMDA blockers, including dextromethorphan, the opioid that is not used as an analgesic. But they are all weak. The most accepted and potent NMDA blocker is ketamine. Here's a part of a review by Cousins and others. Michael Cousins is one of the world's foremost authorities in Australia on pain management. And they have put in ketamine as a third-line option. But leave the dose alone for the time being. What is the kind of patient in whom you may tend to use this? Your patient who does not respond to the simple application of the ladder, whose pain keeps on increasing, who is also having abnormal sensations, that's a typical patient, and who concurrently also seems to be getting recruitment, increasing in the area of pain in addition to the intensity. That's the typical patient where you may try it. This is given what's called a burst therapy, which is typically given for about 3 to 5 days. The idea being that in 3 to 5 days of NMDA blockade, the dorsal horn quietens down, learns to behave properly, so that the ladder now achieves better pain control. So as I said, this is not only for neuropathic pain. Now, in addition, ketamine also seems to have an intrinsic analgesic action. So even without central sensitization, there may be cases to you, situations where you may use it. Can anybody think of a situation? A typical one is an ischemic pain. Say somebody with a peripheral vascular disease, a pain that is usually not not completely opioid sensitive. Here, this may be a good actuant. Now, this regime given here requires about 5 days of hospitalization for burst therapy. But what if your patient is at home and cannot come to the hospital? Oral ketamine is a viable option. Remember, ketamine is one of those few drugs which is actually more potent when given orally. That's because more first-pass metabolism, more of norketamine, which seems to be more potent. Sunil is here? Yes? Sunil, you corrected me on this some years back. I still do not remember. I said it is more potent and longer acting. I think you corrected me by saying that it's longer acting, but not more potent or something like that. Anyway, I'm sorry, I should have looked it up earlier. So here is also a dosage regime. Anesthetists particularly, please note, this is such a tiny fraction of what we use as an anesthetic. Which will mean for somebody like me, your starting dose may be 10 milligrams, and you may build it up to 25 milligrams 6 hours later. Now, you have enough backing by scientific literature to use it as an add-on therapy. But for those who, I have talked about the new understanding about side effects to many of you, but for those who have not heard about it, there are two major points of caution, especially in the last few years, from experience in mostly from American emergency rooms of treating people who abuse ketamine as a recreational drug. They have found some adverse effects that we did not know of earlier. And one is its significant potency for hepatotoxicity. Now, is that a theoretical proposition? My answer is no. This is very real. After we saw it only in 2012, but after that, we started the practice of checking SGPT first before starting it, and then repeating it after 3 days. We did find that in a significant number of people, hepatic enzymes started rising. When they start rising, we withdraw the drug because we do not want to risk a permanent liver damage. And what is the second toxicity? It is a surprise. It is vesicopathy. So what I do now is, if we are starting ketamine, every day we ask the patient, is there any burning micturition? Ketamine, we still don't know why, but ketamine causes burning micturition. The culture would be sterile, and we may not associate the two. The risk is heavy that the burning micturition after some time may become irreversible. You will withdraw your ketamine, but the patient may continue to have vesicopathy. The artist has come now. One of the team is an artist who likes to, my session is so boring that somebody is putting in some color into it. Thank you. Is it from here? Okay, doesn't matter. See, those lines have nothing to do with my presentation. It's not deliberate. It's not struck off. So, hepatotoxicity and vesicopathy are the two things for which continued monitoring is necessary when we are using ketamine. Okay, that's 9 step out of 10. I do not have another intervention to suggest. My step 10 is acceptance. Look, despite whatever we do, in difficult pains, there will be a proportion of patients, maybe as much as 5 to 10%. It is 10% when we do not have everything in our disposal. It may be come down to 5%. Again, that percentage I am not backed by evidence, in whom we will not achieve unsatisfactory pain relief. The problem then is that we feel such failures that we may emotionally run away from the patient and the patient may feel rejected. Time and again, I have sat down with patients and confessed, I know that I have not been able to relieve your pain satisfactorily. I do not have another medicine to suggest, but what I promise to do is to be here for you. How can I help you to live with the pain? And I'll also convey, if by any chance the pain seems to get even worse than now, maybe I need to see you again. Maybe there are things that we can do. These would be my main messages. I will not desert you. I will walk with you. How can I help you to live in this pain? 2, if the pain gets worse, we'll be here to see what we can do about it. Of course, if it is only in the context of cancer, and if it's in the context of a patient approaching death, we have the choice of palliative sedation. Unfortunately, in many other situations, in many chronic pains, we have nothing else to suggest except trying to help the patient to live with the pain, including with occupational therapy, diversional therapy, and possibly with cognitive behavioral therapy. Thank you. We'll keep the presentation on because periodically we may have to go back to the presentation. If we can minimize it and have the presentation available for discussion, that will be good. Mary?
I want to know how's oral ketamine? I've not come across it. So is it available and how do we procure oral? I've not come across it.
Mary, thank you very much. I should have mentioned this. My apologies. Ketamine is not available for oral administration. What we do is to drop the injectable medicine, dilute it appropriately with a well-sweetened drink. Many of the preparations are very bitter, and I would recommend that if the patient is not on an antiemetic, we also give a prophylactic antibiotic because it can induce emesis. Well-sweetened tea, well-sweetened coffee, fruit juice, something like that, you will mix the ketamine and give it as a drink. Injectable ketamine diluted appropriately. When the patient has to be sent home on ketamine, oral ketamine, again we dilute appropriately in a syringe so that 1 ml is 1 dose and send the syringe with.
Thank you.
Sir, how is the route sublingual for ketamine?
In the Indian context, when for incidental pain, like a patient with bony metastasis wanting to walk to the toilet, but the movement causing intense pain. This has been tried. So there was a time when we used to do it quite a bit. Ketamine does get absorbed through the mucosa. The two problems are that one, the bitterness of it, very bitter and not easy to tolerate. But still, we have had patients who would have opted for the bitterness. Doesn't matter, I'll have it and take it. The second problem is not every patient, but once in a way, someone gets very severe mucositis, some kind of mucosal reaction, so that there's a lot of ulceration in the mouth. We have tried in those cases when they needed desperately combining corticosteroid and giving it, but still once that happens, we had to withdraw. So there is not much literature about it. But it was described in literature. That's when we tried it. And if somebody desperately needs it, I would still do it.
Then what would be the dosing like in comparison with the per oral dose?
What I'll tell you what we did. That's all I can tell you. What we did was to stick to 0.2 milligram per kg. That's for a 50 kg person. Just because I am 50, I'm thinking everybody is 50. Anyway, for a 50 kg person, it is 10 milligrams, 0.2 milligrams. But a word of caution, there is very little in the literature about sublingual ketamine. Not everybody, and most people do not like it. I mean, most patients do not like it because of the bitter taste. But if the pain is so severe and they are helped by it, they love it.
Sir, post-chemotherapy pain, peripheral neuropathy, what are your suggestions? Duloxetine, is it preferable over others?
Nandini and others, everybody else. If anybody has studied that recently, please educate me. I must admit that it is many years since I looked up specifically either chemotherapy-induced neuropathic pain or neuropathic pain related to ART. Both these are a bit difficult to treat. What I still do is to still start with tricyclics. I do not know that specifically duloxetine has a recommendation, but then as I said, anybody who can give more educated information on that. So we look up the literature, okay, later, and maybe come back to the group with what we find. No. Sunil has something to say.
Regarding oral ketamine and its metabolism, when we norketamine, which is the metabolite of ketamine, it is less potent as an anesthetic agent, but it is equianalgesic as that of ketamine. Norketamine is equianalgesic as that of ketamine, and when you give orally ketamine, more of norketamine is produced. So that's why even with oral doses, ketamine can produce analgesia.
So, correction to what I said. I earlier made a claim that norketamine may be more potent. Sunil's correction is that no, it is equianalgesic, but because there is more of norketamine quantitatively, it's more effective as an analgesic when given orally.
Yeah, that's the explanation given in palliative care formulary. And the sublingual dose described is also same as the peroral dose. Like there is no specific dose per kilogram mentioned in palliative care formulary. It has just given a range of 10 to 25 milligram. perorally or sublingual. Even though sir has told
Number
that
It is
the
the same.
kilogram, yeah, that's what.
That's practically the same. 0.2 to 0.5 milligram per kg. In a man like me, will work out to 10 to 20.
Centers are open to share some difficult pains that they can remember and bring it to discussion here. We have, at least half an hour left, isn't it, Vidya?
Yes, yeah. Mary, you want to ask
Mary,
something?
Yeah. You remember once a case that I presented about a girl with ALL who had, that was in the beginning
with
of
foot.
it, yeah, who had chemotherapy-induced neuropathy. Subsequently, in the terminal stages, that was sometime in March, she developed severe leukocytis because she was a very, very strong chemotherapy drug at the last rescue, because they had given up. She felt she was resistant to chemo, so they put her on some very, very strong chemotherapy drugs, and she developed severe leukocytis. And leukocytis later on became cellulitis, and her whole face had got swollen up. So a complication which was even worse than the chemotherapy-induced neuropathy. And unfortunately, that was not responding to things. So sometimes what I said, the side effects of chemotherapy can be worse than the original cancer kind of thing. So this girl ultimately had very, very bad cellulitis. Her whole face had swollen up, which was of course not responding to morphine infusion, and pregabalin she was getting once a day. So in these kind of patients, they were also giving her the local anesthetic spray in the mouth and the gargling and all, but never really helped her. So in such kind of situations, I don't know what can be done. Just a question, I thought.
Sir, you're muted.
Do you think corticosteroids might help in that situation? Anybody knows? In chemotherapy-induced cellulitis, if it is a question of inflammation, of unexplained reason or unknown reason, what we usually do when we don't know what to do is to give corticosteroids. Mary, do you know if this patient had been given corticosteroids at all?
No, certainly. She was admitted in AIMS, and the pain team there was looking after her. And the only drug that she was getting was pregabalin. The rest was all the local anesthetic, nothing else. For certain, she didn't receive steroids because I was there with her towards the end.
So if we have to look at that case, I mean, I would like to discuss with this group whether first, whether the infusion and the dose of morphine or whatever opioid that was chosen to be given, was it adequate? Was it adequately titrated? Because, sir, if we look at inflammatory mucositic pain with cellulitis, it's mostly nociceptive. And combination of anti-inflammatory and analgesic, strong analgesic should at least take care of the pain part of it. So, I mean, as a theoretical discussion, because we don't know details.
It could have a neuropathy element also, because with that kind of a thing, I'm sure some nerves also would have got involved. So it could be a mixed type of thing. There could be a neuropathic element also to the nociceptive. That's what I feel.
If such a patient was in pain and the team did not use opioids, well, they must have tried. And maybe it's pain. That might be the
She was
reason.
on
Yeah.
opioid. She was on morphine infusion.
Okay.
Hello, sir.
Iqbal?
Hello, sir.
Hey,
There is
Iqbal.
lot of so we switched off toward the mobile, sir, because there was problem with the laptop, sir. So as madam was telling that, sir, in due to severe swelling of the face due to post RT. Also, we have seen some patients, sir, patients who are suffering from peritonitis, sir, because of poor oral hygiene, also due to immunosuppression. So, in this cases, ultrasonography of the face is sometimes beneficial to show whether there is any peritonitis swelling, and we can give antibiotic to take care of the pain, sir.
I think you would also would be pleased to know that Iqbal is also a sonologist, carries around a handheld ultrasound, and I am amazed at how much benefit it can do to a palliative care doctor. So many of our doubts are allayed. I mean, in several situations that can remarkably help. But that's a great piece of information from somebody with that personal experience. I'll remember that, try to remember that Iqbal, that when we have find the whole face swollen, it could be parotitis also as a major component. And parotitis causes pain that's not at all easy to control, mainly because of the swelling that it causes and the distension of the capsule.
Thank you,
Thank
sir.
you, thank you, thank you.
Thank you, sir.
While somebody else is thinking of a question, among the adjuvants, one thing that I did not bring is local application of local anesthetic. Sunil, at the moment, is managing a person with peripheral vascular disease upstairs in the inpatient unit. Sunil, want to tell them about what all medicines he is on and what is the role of local anesthetic there?
So this is a 25-year-old man who has peripheral vascular disease. He came to us with decreased vascularity with a gangrenous toe, but he had severe pain on the shin and thigh. We did a chemical embothectomy with which patients, most of the pain was taken care of. He says his pain on the shin and thigh was relieved, but the gangrenous toe started to have more pain, and recently 3-4 days back he had a disarticulation. So he was referred back to us after disarticulation, and he was complaining of severe pain. He was saying that I don't have pain at the disarticulated side, but he has pain in the surrounding areas of disarticulated toe. So what we did was we used 0.25 percentage bupivacaine, and
On
that,
the wound.
on the wound, yeah, on the wound, and with that application, the pain on the surrounding area was relieved.
So how frequently are you applying it?
So now he is previously it was 6 hourly, but as his pain relief was not under control, we made it 4 hourly, and now he is getting more pain relief. Means only need to give local anesthetic 6 to 8 hours.
So while we are on it, could you tell us something about local application of non-steroidal anti-inflammatory solutions or ointments, both for example, for mucositis, how useful is, say, Dispirin gargles, and how useful is a Overon gel outside on painful areas like arthritis or wound? And for what Iqbal is doing, can Overon gel replace the KY gel when you're doing it, whether it will help?
Sorry, I mean, like, oh, okay, okay. As you need to apply a conducting something or whatever on the skin for the ultrasound. Okay. Nandini, I don't know. You asked about not only about the aspirin gargles. I don't know the answer to the question how effective it is. Do you? Have you tried it? What's your experience?
It has been variable. I often try it because it's so easy, and person can feel immediately benefit. And they have, I don't know whether it's placebo effect, but sometimes it helps. But I don't know. I have never read it anywhere. But this was told when we got trained the first time in Calicut, when all of you all were there in Calicut.
So the theory will be that NS, non-steroidal anti-inflammatory drugs, act by inhibiting prostaglandins, thereby treating the sensitization of the nociceptors. And in mucositis, whatever we apply are almost directly hitting the nociceptors because it's mucosa, especially when inflamed. You are straight in contact with the nociceptors. So there is clear reason why NSAIDs can be effective. Now, how effective it is, I'm not so sure. Now, the transdermal application of NSAIDs, like over and gel, or now many sprays, NSAID sprays, etc. The idea is that after minimal, the local absorption is minimal from skin, but whatever it is, achieves a high concentration. So you are applying, say, 10 ml or 10 grams of the stuff onto the skin, and only 0.01 milligram really gets absorbed. But that is concentrated on the local nociceptors, or at least that's the belief. So the local effect will be significant with the little absorption, is the theory. Some people are quite helped by that up to a point, but generally about all local applications, have you noticed, even when you have not recommended it, people apply all sorts of things locally. There are two things I think, in addition to any true therapeutic effect it has, you do not have anything else to offer. Here is something that they can do themselves, something that they have control over. They feel a little more confident, at least I can do this. And the second thing is, of course, massage. We are human beings. The majority of human beings like massage. It is also the sensation, especially somebody does it with love. It's very comforting. So I think it's a sense of control also, in addition to the minimal therapeutic effect it will have.
Mary?
Yeah, it also the gate control theory also. No, most of these local massages and creams and balms, I think they also act by the gate control. It allows the A beta fibers to get through and prevents the pain. I think that could also be part of the thing. The way these creams that are applied on the skin, or tents, or anything for that matter, maybe that's how they produce pain relief also, I think.
So transdermal patch is also available these days, sir, in NSAIDs.
Is there any idea how expensive they are? No. Okay.
Around 100 or 120. Sir.
And
it's a daily, like once a day patch.
Diclofenac patch.
so once a day it will work out like the same cost as a 25 microgram fentanyl patch. 300 rupees in 3 days. Okay.
Even lignocaine patches are available. Lignocaine patch.
Lignocaine patch. We used it very, very successfully in one man with a very severe allodynia. This man had following a spine surgery, the tailback syndrome, and one area of his flank was in very severe pain. And we had some donated lignocaine patches, which, to the best of these 10% lignocaine patches, to the best of my knowledge, is not sold legally in India, but it's available. Everything is available. You're muted. Mary, you're muted.
Zydus Cadila, they are making the lignocaine patches.
So it's available, sold here.
Yes, yes.
Okay. How expensive is it? You don't know.
I don't know the cause.
Maybe, I mean, like all of us should do this exercise of knowing the cost. As important as pharmacology, at least as important as the pharmacodynamics, and this is the pharmacodynamics on the wallet. Very important.
Sir, capsaicin, please. Your experience with capsaicin.
Like in the 1990s or thereabouts, capsaicin came up as a big thing. So possibly this also comes down to what Mary mentioned as the gate control theory. That is, you reduce the low, or you in this context, no, this is the counter principle. You increase the input, no, the sensory input from the side. Capsaicin stimulates peripheral nerve endings. You increase the sensory input so much that at the level of the dorsal horn, there is some inhibition of the sensory perception, the pain perception. That's the idea. There is some effect for some people. Capsaicin, unfortunately, is expensive, and the difficulty is you certainly cannot use it in areas which are already having allodemia, because it's an irritant. Even in normal skin, it can cause severe burning sensation. Some people find it tolerable, others find it very bad, and my own personal experience is zero. Anybody with personal experience on capsaicin? Anything?
No personal experience, but capsaicin acts on vanilloid receptors, and it at first if capsaicin is applied, the receptors are upregulated, so that at the first application the pain will be increased rather than decreased, and after some time, because of some other mechanism, the pain will come down. That's what the theory says. I don't have personal experience in using capsaicin.
Maybe here in India, we should start using chili powder. The origin of the capsaicin.
Yeah. Hello everyone. I've used capsaicin gel is available as Clonnerve gel, which has 0.075% capsaicin. So I think in neuropathic pain, definitely it works very well. But yes, as sir mentioned, the patient who has allodynia at the same site, or at the where already the place is inflamed, at that point definitely we can't use it. But otherwise, neuropathic pains, it works pretty well. Thank you.
I don't think I have met you. Where do you work?
Sir, at present I'm working in Venkateshwar Hospital, Dwarka, Delhi.
Nice, Mary.
Thank you, sir.
We have Gaurav as well. He is a new participant. Gaurav, can you introduce yourself? No.
Please unmute yourself, Gaurav.
Can you? Okay. I think he has some problems.
Gaurav is from?
Megha, can you introduce Gaurav?
Dr. Gaurav and me actually both, we were working with Dr. Sushma at AIMS, IRCH Delhi. And at present, Dr. Gaurav is working with Delhi Pain Management Center as a consultant.
Thank you, Megha.
Yeah, ma'am.
Sir, I have a question regarding, recently we saw a patient with psoas syndrome. So if a patient has some muscle spasm, if it is a psoas or a piriformis muscle problem, we always usually concentrate with the cancer-related problem, whereas the patient can present with simultaneously with other problems. How should we manage this patient?
Vidya, actually, none of us is blessed with an interventionist spouse. So why don't you first tell us what you did between the two of you?
No, sir. It's for a patient. Vijay works in a different hospital, so I can't ask his help to do an intervention.
No, but like okay, one. I'll tell you what little I know.
Okay, sir.
One unfortunate part is when there is intense spasm on the muscles, our first thought is about giving muscle relaxants, skeletal muscle relaxants, like carisoprodol or baclofen. Unfortunately, it does not work very well. The simple fact that if we want to give enough systemic muscle relaxant to relax spastic muscles, that will relax the normal muscles so much that the person will feel intensely tired. So that's the unfortunate part of it. So the best attempt, why I specifically asked for Vijay is, if we know the cause, the site of causation of the spasm and relieve the spasm, of course, relieving the spasm is the best thing. Otherwise, I'll admit that it's a bit difficult. Now, about the mechanical, apart from the idea of still using baclofen, say usually up to 10 milligrams 3 times a day will be reasonably tolerated. Maybe it'll help up to a point, or you will use a non-steroidal anti-inflammatory drugs if possible, because after all, it is a nociceptive pain. It is associated with prostaglandin stimulation, and it should help up to a point. I would certainly try paracetamol 12 milligram 6 hourly with another with ibuprofen 400 milligram 3 times a day, along with gastroprotection, unless the kidneys are involved. So these are things I will do routinely. I don't know how much opioids will help. I would be willing to try that, at least to tide the patient over the preliminary period. But I should also think that this kind of pain is one where one physical measure, application of heat, should work. Now, sometimes, especially with all that happens on the cricket field, so visible in the television, there is a great popularity for ice packs. So when there is muscle spasm, I would not use application of cold. On the other hand, application of heat might help to relax muscles. So these are the only things I can suggest. What did you do, Vidya? How is the patient?
So the pain is relieved with paracetamol and tramadol, but she is a little bent over, when she walks, and I think she says there's a pull on her back, and I was not sure how to manage that. That's the reason
is there an abscess? Sorry.
No.
No, just whether it has anything that has helped, which shows some collection within the muscle or underneath the muscle.
There is no abscess or any collection. They've done an MRI, So nothing specific. There is a mass adjacent to the psoas muscle. That is the reason for the spasm. That's what I'm thinking.
Nature of the mass is? Do we know what kind of mass that is?
It's a retroperitoneal mass. She had a history of CA endometrium. Now she has developed a retroperitoneal mass.
Oh, I see. And that's a malignant lesion, right?
Yes, sir.
So would
Yes.
that would there be a role for palliative radiation there? Because if we cannot remove that cause, I can see the future as being very difficult.
Yes, sir. Yes.
And if it comes to the worst, we may have to put in an epidural and keep it there for as long as possible. I can't think of another way of relieving that spasm. Of course,
They are looking
try.
for whether there's a role of surgery in it, but I'm not sure, sir.
But I hope you will also try application of heat for what it is worth. Sometimes it does help more than we expect.
Will do, sir.
Since this is the last session of best practices in using opioids, are there any clarifications regarding using opioids in different situations also? Because don't think of it as a single lecture. This is the end of the whole session. We will not be continuing this topic eco. This is the last one. Okay, no questions. I think we had several occasions to ask. And of course, the other one, multimodal pain management, has begun. I hope all of you are receiving the invitation regularly. It will be covering methadone, and after that is over, it will be physical, non-pharmacological physical therapies specifically for managing, from the viewpoint of managing pain. Then there will be psychosocial aspects, again with the viewpoint of managing pain, and interventional pain management, mostly about selection of patients and what we as non-interventional pain management people need to know about the intervention so that we know when to refer and what we should keep in mind. It will not be a class on actual techniques, except maybe a very, things which we can do probably in our own clinic. Then there is something on, I think, making sure, Sunil, what is the last topic? Making sure of getting an RMI status for institutions, right? Yeah. Getting an RMI status for the institution, the hitches and what needs to be done. So that will be the last session. So if anybody is not getting the invitation for this particular eco, let us know. And Vidya has sent all of you a survey to know about the effectiveness of this 11 session eco. Please take out 5 minutes to fill them. It's all, ticking. There's nothing that you need to write. It's just ticking as to how you felt. And there are some questions. You just need to choose the different choices. Vidya?
Yes. We have received around 12 or 13 responses so far, and I'm looking forward to more responses so that we can analyze the data and share it with, like if any other center wants to recommend ECO, then we can share our experience with them. It will be nice. It's been a journey for me, learned a lot, met many people. Though virtually it feels like we had a personal connection. We will miss you. But of course, we'll be seeing in the future ECOs and everything. Please do participate actively in other ECO programs as well. Thank you. Sir, you can say something.
No. I mean, it has been quite a journey. Nandini, Vidya, particularly for taking the lead and making this happen. Nandini, I am positive that we wouldn't have got here without you. And Vidya, this was Vidya. I mean, you have taken up a full-time job. Otherwise, I think you should really consider being an anchor in some television show.
As a backup job, sir. Yes.
But you have been phenomenal. Thank you very much. I mean, this is quite a warm feeling. I mean, we are on the brink of something new because this kind of electronic revolution certainly needs to be nurtured. It has great opportunity for the future of learning in this country and elsewhere. So I am very grateful to you all for being part of it. Vidya Vishwanath, you have been very quiet today.
I was just had a death in the morning right here in the hospital. So didn't start off very well, and so finished that and then came in. Somewhere. That was right. And I don't like Vidya saying bye. Somehow I don't like that at all. Vidya.
Your
This is for
voice.
Vidya. If we don't say bye, we are going to continue seeing you, and we want to see that smile flash on. So, please. All right.
Of course, we'll keep connected.
Yeah, and there is so much of when you were talking of mucositis, there are so many times when we have a problem. I hope that we can send forth those problems and get responses. Dr. Nandini, could you create some kind of forum where we could put in those cases and get a response at some point? I don't know how, but because if we have a problem case, how do we share it and how do we go about it even in future? So it would really help.
Yeah, we'll discuss and get back to you. Yeah. So since we have echoes, so many coming up, I think we should just have it discussed in those meetings themselves. Let us see how we can do. I saw your message also. Thank you for that. That's a good idea. Yeah. Thanks. Mary, you want to say something?
Hello.
Just wanted to say a big thank you. Sorry, I'm so sorry. You carry on.
A big thank you to you, Mary. You have also been continuously, and for every session, I think some of you have been there. Not a single session, I don't think you have missed any of these sessions.
I just missed one session when I was out of station, but I must tell all the hard work put in by all of you. It's really, really phenomenal, and really, I really want to thank you all. Okay, I can't even mention names because so many people have done so many things.
Yes, that's true.
That's great. It's been wonderful.
Thank you. Megha, please go ahead. Sorry.
Ma'am, first of all, I really want to thank all of you because it has been a great session, and I haven't met any of you, almost none of you, but it has been a great pleasure. Learning from all of you. And I have a suggestion regarding what Dr. Vidya was saying. Probably we can have a WhatsApp group, which where we can share our cases. We have I am a part of one or two groups where we share our cases and difficult cases, and we all give comments to that. So that is a very comes as a handy thing, that whenever we are in problem, we just text it and some or the other person gives a response. So that's just an idea.
Come before the camera. Let us thank Vishnu. He is the man. Neither he nor any of us knew about ECHO, and somehow he made all this happen, and it has been a continuous learning process for him and for us. So Vishnu, just introducing the man behind the screen to everybody. Thank you.
So please get Manoj also if he's around, because he is. Is Manoj also around?
Megha, it's a good suggestion. We do have some WhatsApp groups for palliative care. Maybe we will try to add your number to it. Just send me the mobile number to us. Okay?
Sure, ma'am. I'll do. Thank you.
Dr. Akil, you have been a very silent observer throughout the sessions. Do you want to say something?
silent but very regular. He has always been there. Akhil,
Yes.
Thank you, sir.
कुछ तो बोलो यार.
Sir, good afternoon, sir.
Good afternoon.
Sir, I have two questions, general. In many of my patients which is on morphine develop refractory headaches, idiopathic, no pathology diagnosed, and some of the patient of abdominal tumor develop spasm of voluntarily hypogastric and epigastric muscle. So what is the best approach for this and management?
Akhil, I am not sure that I understood exactly. And please readjust your camera. Your face is not visible. Did somebody follow Akhil very well? Like you said something about an intra-abdominal tumor and hypogastric pain. Is that it? Or
what spasm of hypogastric muscles and epigastric muscles.
Okay,
patient is on morphine treatment, but patient develop hypogastric muscle spasm and epigastric muscle spasm without any pathology.
When you say spasm,
idiopathic.
Idiopathic. But you said something about a tumor in the abdomen, didn't you?
Intra-abdominal tumor, but on a CT scan, no relation with this spasm seen.
No,
what is the reason behind it?
Is the tumor itself pain? No.
No.
Is the tumor painful? No.
No, sir.
I mean, like
why patient develop spasm of hypogastric muscles and epigastric muscles.
So what you mean is
reason
the patient feels the spasm and you can feel the rigidity. Is that
no spasm only, no rigidity or.
No, what do you mean
painful spasm? Painful.
What do you mean? Is skeletal muscle spasm or are you talking about
skeletal?
I mean, if the muscle goes into spasm there, you should be able to feel the rigidity there.
In hypogastric region. Like bladder, urinary bladder feel होता है ना, like this, but it is not bladder.
And it is continuous or only in between?
Continuous.
And nothing seen on ultrasound or anything. No reason.
Ultrasound में no bladder and everything is normal.
And is the muscle abnormality all round the abdomen? No, it's only in the hypogastric.
In other case, I have seen refractory headaches without any abnormality or idiopathic. I say idiopathic refractory headache of head neck malignancy patients, which is treated by morphine.
Which is treated by morphine. Created by
morphine.
Headache. Now, Vidya, it would have been so much better if you had allowed Akhil to be quiet. He's asking all kinds of typical questions. By the way, Akhil, I'll come back to you. Here is Manoj with Vishnu. Manoj is our CEO of Valley India. So he has been also part of the struggle and getting the technical build-up. So Manoj, the first season echo, and people wanted to see the men behind the technical expertise.
So hi John. I'm happy to see that it is very effectively utilized by all the resources. And thank you to Nandini, Vidya, and the entire team who is behind this venture. And hats off to all the team. It's not only because of the technical support that we have given. Definitely, it is a team effort, and I hope that it will keep on going. Thank you.
Thanks to you, Manoj. Thank you so much.
Yeah, thank you.
So, Akhil, coming back to your patient, I was thinking, like the hypogastric muscle spasm that you described. It's a bit difficult for me to understand. if, as you say, there is no pathology at all, it is not a root pain, not around the abdomen. It's only a
Yeah.
muscular spasm in the hypogastric
Spasm.
area. But you also
Skeletal.
mentioned an epigastric spasm.
Epigastric. matlab, in some patients, I have also seen epigastric spasm.
Oh, you mean
skeletal?
You're talking about different patients.
Yeah.
Okay. So that you are, leave alone the headache. Now you are asking, could the morphine cause such a spasm? Is that it?
Yeah.
Oh. Does anybody know anything about something muscular reaction to that?
I know that fentanyl causes muscle
Yeah.
rigidity. It's one of the known side effects, but I don't know about morphine being the cause. Are you? If it is one patient, if you can, we can discuss that. But if it is as a general phenomenon, that morphine causing muscle rigidity, then I'm not aware of. I don't know, sir.
Akhil, that's rather strange, and we need to go into that more. Maybe we'll have a Skype chat or something on another occasion. I need to have it. Next time you see something like that happening, let us chat about it with one of us. Maybe we can even see the patient virtually on the mobile phone, mobile camera or something, and seek the solution, because the other is quite understandable. Morphine is known to cause headache in some patients, or more likely, morphine worsens some headaches. So it's well known, it is a described entity. We don't know exactly why. Somebody with a history of headache, that's idiopathic headache, getting morphine worsening the headache is a well known entity. And there we do not know the reason, which of course tells us that morphine is never a first-line medication for headache. Though for a headache of an elevated intracranial tension, morphine would have an almost adjuvant role along with the primary management with corticosteroids, but not for idiopathic headache. But the muscular thing I don't understand at all. So next time you have that, maybe we'll organize this. If you have a patient in the ward and not in the outpatient, maybe we can adjust a time and we can actually see the patient and see what's happening. Akhil, by the way, has recently started palliative care center at Indore. There has been so little palliative care, and he has an amazingly large number of patients being treated. Congratulations, Akhil. Okay, I think
So
all good things eventually come to an end.
Yes. Vidya, can you just conclude?
Thank you. As customary, I'll send the article and PowerPoint and also the summary and recommendations. Thank you all.
Can we give a loud virtual applause to Nandini and Vidya particularly? Thank you. It's been a great pleasure. Thank you, everyone.
Thank you, sir. Thank you very much.